Hey, everybody. Welcome back to another episode of Between Sessions with Berries. I'm excited. We have a two-time guest today. This is her second time coming back. Barbara Griswold is here with us. You guys might have listened to her recent episode on progress notes, which was amazing. And now we've got her back to talk about treatment plans. But let me do a little intro first. Barbara Griswold, LMFT, is a private practice coach and author of Navigating the Insurance Maze, the Therapist's Complete Guide to Working with Insurance and Whether You Should, 10th edition. She offers online courses on insurance, notes, documentation, billing, and the business side of private practice. All the stuff you never learned in grad school. She invites you to check out all of her therapist resources at theinsurancemaze.com. Barbara, welcome back to a second episode. We're talking about this topic that everybody loves, right?
No. I said to you before we started, this is the one that I think everyone hates maybe almost as much as HIPAA. Maybe HIPAA kind of edges it out.
I would agree with that. I hate a treatment plan so much.
Yeah.
But you're the expert on these, so I'm glad you're here to talk about them.
But my confession is that the first 30 years of my practice, I didn't do them at all. Never once.
I can't agree with that too. I would occasionally do them, but there was no regular cadence or me really keeping up with it like I should have been.
So I did this survey in like 2022 or something, 500 therapists. And one of the questions I asked is, come on, let's get honest. Do you do treatment plans? And 60% said that they don't do them regularly for all clients. And 40% said, yes, I do them for all my clients, which I find it sounded hard to believe, but okay. But even then, most of us think everybody else out there is doing them and I'm the only one who isn't, where actually, if you're not doing them, you are in the majority, that 60% of us are not doing them. And after 30 years of not doing them, and we can talk about all the reasons why I didn't, I started to do them. And something changed out there in the industry where this is something that insurance plans started to use against us in a way that I probably shouldn't say it that way, but they started to use it as an excuse to not pay. So they became more picky about what was in our documentation. They started looking about what was in our documentation, and they wanted to see a certain type of thing in our treatment plans that they had never trained us to do. And we had been never trained to do. So then I started to get on the, okay, we don't have to like it bandwagon, but we have to figure out how to do it. And if I'm going to have to do it, I'm already a busy therapist. Tell me how to do it quickly to meet the criteria as fast as I can and move on to the next client who I need to give my attention and clinical skill. And so that's what I've turned around and tried to teach other therapists is, how fast can you get this criteria done? What is the criteria? Because that's one of the reasons we talked about why don't therapists do it, besides the fact that we are all way too busy. We don't necessarily see the reason to do it. Why should I write down what my plan is? Why can't I just do my plan, right? But some of it is none of us were taught how to do a treatment plan, what is supposed to be in it, what are insurance plans looking for. So it's really hard to meet a criteria when you have no idea what the criteria is, right?
Exactly. I was just going to say, I'd always have in the back of my mind, like, I really should be doing this. So it felt like this burden chasing me around, even though I wasn't doing them. You know what I mean?
And then one of the things that we'll talk about later a little bit more is, well, when you and I as clinicians talk about a treatment plan, we're going to think about one thing. And what the insurance plans want to see is a different thing. So you and I might talk about that we want to improve this person's self-esteem. Well, that's something an insurance plan doesn't really care about. They don't really care about your client's self-esteem or a better relationship with their mother. They don't really care if the person has a better relationship with mother. So your written treatment plan or what the client even comes in and asks you for could be something 1,000% differently than what the treatment plan is that you would write to go in a clinical chart. So we have to learn to, I don't know if I want to call it double speak, but
well, it is.
For myself as a clinician, what I thought about is in the first session that I have a sense of what my client and I are working on, and I never lie, but there is a set of goals that the insurance plan is patting me in the head and saying, okay, we think that there's enough here for us to cover. And then there's another set of goals that is over and above that, that might be more personal to the client that we're working on in terms of their relationships or their self-esteem or that type of stuff. So we have to learn to separate these and not put all that stuff in the treatment plan about, like we said, better relationship with mom. There's going to be stuff that doesn't go in the treatment plan, and you can have it as a little side in your notes. But the one that you can pull out and hand to an insurance company or send into it is going to be different. And that's what I'm going to teach you to write today. And you don't need to put everything in a treatment plan. You just put the bare minimum that says, yes, this person has some symptoms of a diagnosis, and here's how I, as a clinician, plan to treat that diagnosis. Not the uncool stuff going on in their life that they wish were different, like that they're lonely. Yeah. That's not probably going to be on the treatment plan. Although there may be ways to put that on the treatment plan. But anyway.
Do you think that's why we hate to do them anyway? Because we don't know how to word it correctly to meet medical necessity? Which
I'm going to give you. I'm going to give you the formula.
I love it. I love that.
Yeah. I figured out for myself that there's 2 sentences you can use for all your clients practically. So...
Oh, I want to hear that. Yeah. First of all, I want to say it shocks me that we're not doing treatment plans because I would assume that you were always doing them.
Right.
Yeah.
For the first many years that I taught, I didn't confess that. Yeah. Because I was still working with insurance plans. I
didn't want to get in trouble.
But then after a while, I thought, they're not attending my workshops. So then so many people came up to me afterwards and were like, oh, that made me feel so much better. And
yeah. Oh my gosh, definitely. So we don't do it because one, we don't know how to. Two, the problems we're having to put down maybe aren't the problems we're actually wanting to work with our clients on. A lot of people, I guess, don't make the connection like, let me just figure out a better way to word this so it meets medical necessity, but we could still work on the goals that the client actually wants to achieve, I guess, is a way to say it.
But we need to know how to do it because sometimes an insurance plan will contact you and say, okay, I want to review your care with this person. And one of the questions they're going to ask you is, what's your treatment plan for this person? You need to be able to put together a treatment plan that could, in a couple sentences, outline your ongoing care and why they should pay for more sessions with you. So even if they don't touch your documentation, you need to be able to put together a treatment plan that they're going to say thumbs up or thumbs down because, well, no, they're going to say thumbs up. Because if you're on the phone with them and you say, well, we're going to work on the relationship with mom and her self-esteem, they're going to be like, well, we're not paying for any more sessions then. And suddenly your lack of knowledge about a treatment plan has screwed your client, basically.
Yeah.
So that's the one thing that made me turn around. And the second thing that made me turn around and start teaching this was, as I said, that insurance plans are starting to look for this more, starting to use it as a denial excuse more, even for people who had perfect notes. Especially Medicare did this. So a couple of therapists I knew that said I had perfect notes. They said wonderful things about my notes, but then my treatment plan, they asked for money back for all of the sessions because the treatment plan that was in place for all of those sessions they didn't think was medically necessary, which we'll talk more about because people don't always know what that is. So this one not little thing, but this one thing can screw you even if you've done wonderful care for a client and wonderful notes and you've done everything else right. So we don't want this to be your that rock you trip all over and go flip.
Absolutely. Yeah, and I'm sure we'll get to it. But the other thing that and I kind of said it earlier, but the thing that always got me is like, I didn't know how often really I should be doing because I feel like all the insurance companies have different, like some want 90 days, some want 6 months, some say annual, you know, and it felt like overwhelming to even try to keep up with all of that.
Worse than that, they don't tell you how often that they want you to. I actually read the provider manuals and it's almost never in there. It may even say that we want you to update them routinely. Or it may not even mention how often or that they need to be updated. But then when you go, they ask for your updated. Well, it didn't say anywhere that you had to update. You're supposed to know things that there's no way you can know. And yes, each insurance plan is different. And they don't say what they want in the treatment plan.
Yeah.
And they don't say how often you need to update it or how. How do you update it? What do you mean update it? What's the definition of that? So The thing that I teach in the template that I've given Barry's is kind of one that I think will meet Medicare standards, Medicaid standards usually. It's probably not far beyond, but it's probably beyond what many insurance plans require. But I'd rather have you quickly meet these criteria, and then you're not going to be opposed because you didn't include this one thing that they want. But I would say in terms of, since we're hitting how often do you have to update it? Most insurance plans, they don't usually say. So I would say every 6 months is probably fine. Medicare is usually 3 months.
Okay.
So I would say if you're working with something like Medicare, okay, and maybe Medicaid, you should check with your state. It's a little different. But I would say other than that, 6 months is probably fine. And on that template that I've given has instructions for how to update it, or the last page is like, here's my update information and has a way to update it.
That's awesome. And I want to make sure you guys caught that. Barbara gave us at Barry's her treatment plan template. So it's literally in there now. We're going to talk about it and how it meets medical necessity and all that. If you're not using Barry's or something, you could still follow along and make much better treatment plans, quicker, faster, easier treatment plans. But I just want to say we're so grateful to have it in Barry's because it's just literally now the click of a button, but it's based on this amazing template that we know will pass an audit. And if you do it every 90 days, 6 months or whatever, it's going to make your life so much easier. So I want to say thank you on behalf of all clinicians everywhere for giving us that template. That's amazing. It's like gold to have access to that and just be able to hit a button and have it write it for you. It's so good.
If you look at the template, you probably be a little daunted by it. Like, oh my God, this looks really long. And it's not. It's just boxes and you can just put whatever you want in the boxes. But I'm going to teach you what to put in the boxes. In my mind, probably half of your clients will be depression clients and the other half will be anxiety clients. And so your treatment plans are going to look a lot alike. Now, obviously, you don't want them to be carbon copies of every other depression client, but a lot of them are going to look very similar. And once you get into the hang of it and have the wording, you just can pop it in there. And I do, of course, have a treatment plan training, which will go through with, if you work with a lot of PTSD or substance abuse or whatever, there's different ones you can look at, the goals and things like that. Okay.
No, love it. So exciting. I guess let's dig in. Maybe you'd mentioned earlier, like some people don't even know what medical necessity is. So maybe we could talk about that for a second and then your formula for treatment plans, like try to walk them through like some of the high points. Because I know it's super nuanced and we could go on and on about it probably for hours. But
yeah, so the most important thing about a treatment plan is that you are telling the insurance plan through this treatment plan, hey, someone in this room, whether you work with couples or families or individuals, has a diagnosis, usually more than a Z code, and I have a plan about how I'm going to treat that, right? And when we say medically necessary, so you're proving to them that what you're working on is not just personal growth. It's not just, oh, I wish women liked me better. Or, oh, I really would like a better job. Or, oh, self-esteem issues, relationship issues. They want to see something that you are addressing a diagnosis. And so in some ways, I feel like the treatment plan writes itself. So the medical necessary piece is basically you're saying to the insurance plan, this is medically necessary treatment that's happening here. Just like if I have a broken leg, I have to go see a doctor. This person has something that this is medical insurance. And so a medical insurance should pay for this treatment. So there's a necessity to it. We have to watch those kind of certain terms when we talk to insurance plans. Like we don't want to say, well, he really likes to come talk to me, or he really gets a lot out of therapy because he's grown a lot internally, or he's become in touch with his feelings. This goes under the mistakes. Get more in touch with his feelings. This is not a goal for treatment. Now, again, that might be one of your private goals for treatment. I've had most of my clients need to get more in touch with their feelings.
Yeah, don't we all?
That isn't one I'm going to put down on the insurance plan, treatment plan. And I think that's what you have to think of that. It's for insurance, but it's not just for insurance. For those of you who don't work with insurance, it's also for licensing boards. We have to defend that we are a medical healthcare provider. Why are we taking this person's money? So in case that person ever tries to sue us, we can say, look, I have a treatment plan, and this was my treatment plan, and this is what, I wasn't just sitting here taking their money. for no reason. So treatment plans protect you in that way too. Okay, so medical necessity is basically, yes, there is a diagnosis here. It's more than what used to be called a V code, now it's a Z code of a relationship issue or a parent-child problem. It is addressing some diagnosis at least. Most of our people are come to us with a relationship issue, right? But you need to be looking in that first intake for, is there some other diagnosis? And most of you know how to do that. Okay, so should we talk about what should be on the...
Yeah, let's talk about it. Because you said there's 2 phrases you could use for almost any treatment plan. I'm like dying to hear those.
Well, let me talk about the 6 essential elements of a treatment plan, and then we'll go back and talk about the 2. So I always put diagnosis or diagnoses should be listed on there somewhere. Then this one's not as important. I've never used to put these, but some insurance plans would like a summary of symptoms, just the main symptoms.
Okay.
So if I'm saying depression, you have 10 different depressive clients, maybe just a few words about how this person's depression is expressing itself. Now going to go into the more important one, which is goals. What are the goals of our treatment? Now, don't go crazy with this one. I've seen people with 24 goals in treatment. No, 2, 3 maybe. Now, if they have multiple diagnoses, you may need to but you don't need more than 2, maybe 3. Then here's the one that gets confused. Goals and objectives.
Oh, I'm guilty.
Now, everyone thinks differently about this, and people would argue with me, but what I've kind of come away with is, and I think certain practice management softwares put them together in one, which, okay, fine, as long as you get the main thing. But goals is supposed to be, where do you want to go? And objectives is, how are you going to measure that you're getting there? So if goals is I want to get a touchdown, for those of you who know football, objectives might be to get 10 yards and get a first down. Right. So what are some ways along the way that I can measure that I'm going that direction? And we'll give some examples, so don't worry. And then time frame is 5. How long do I think therapy is going to take? I hate this one the most. This is what I call the bullshit answer, and I always write 6 months.
Me too.
6 months. And then in 6 months
6
you
to 9
go,
months.
oh, I guess I was wrong. And then you put another 6 months or 3 months or whatever it is.
Yeah.
But you know that client who comes in and you're like, this is going to be my 5-year, 10-year client. Don't put 5 or 10 years. The insurance plan will be like, we want you thinking.
We're not paying for that.
I'm not saying to lie. I'm saying think about that. The treatment plan is, what are you planning for the next 6 months? What's realistic? What's the goals that you can achieve? And again, if you're saying my 6-month goal is to have this person less depressed in this way and that way, how am I going to measure that? He will be taking showers daily. He will be blah, 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 blah. So we're going to behaviorally be able to check and say, oh, I'm checking these things and he's moving toward that direction. Okay, and then 6, so let's go over to diagnosis, summary of symptoms, goals, objectives, time frame, and then interventions. Okay, it's not enough to just say individual therapy. What are you going to do in those sessions, right? I don't even think it's okay to say CBT. I mean, that's okay, but let's get really granular. Not just individual therapy, but 60-minute sessions, 45-minute sessions. How frequently are you planning? Once a month, once a week, twice a week? I would say name 2 or 3 main approaches that you're planning to use. They want to see if it lines up. Is for someone who has chronic depression and you're doing aromatherapy, is that something that they want to pay for? So they're going to say, is that the best practices treatment for that particular diagnosis? So you don't have to go on and on and on and on about everything you're going to do over the next 6 months in session.
Yeah.
Give them a general idea so that I could pick up your treatment plan and go, yes, that seems appropriate for someone with that diagnosis and those goals, that's an appropriate treatment. Maybe referrals to group or whatever. So it can not just be what are you doing in session, but it could be referral for evaluation or referral for a group, or it could be a couple quick referrals that you do with all your depressed clients or all your anxiety clients. If you do this well, I think you're going to have a couple of like I said, kind of sample treatment plans that you use with your depressed clients, with your anxious clients, with your PTSD clients, whatever groups you tend to work with more, you're going to get down a couple of. So what are the magic sentences?
Yeah, tell us, please.
So in some ways, I think we fret over them way more than we need to. The magic sentence for choosing goals, which I think is where we get into the biggest part. Anyway, we can diagnose those symptoms, can kind of knock those out. It's going to ask you on the template, how often, the duration of sessions, how long do you think treatment is? But then you're going to get to the treatment goals, and you're going to go, long-term goal 1. But the sentence that I have, and you have to get ready with this one, is reduce frequency, intensity, and duration of episodes of fill in the blank symptom,
Nice.
like depression, so that functioning is no longer impaired. Now, if they're not impaired, you don't have to put that one. Usually our clients are somewhat impaired by their symptoms, but not always. Okay, so let's say it again. Reduce frequency, intensity, and duration of their symptoms or episodes of depression, let's say, or anxiety, so that functioning is no longer impaired. So basically, goal number 1 is symptoms are going to come down.
Yeah. Easy.
So if they're having PTSD symptoms, flashbacks are going to come down. If they're having insomnia, they're going to be getting more sleep. They're going to be having less nightmares. Whatever the symptoms are that your clients are having, you can just take the symptoms that you wrote up above there when I said ask main presenting symptoms, which was number 2. You can just take that list and go, these are going to be less frequent, less intense, or else less duration, kind of like how long they last. So if this person is having depressive episodes every day for 3 hours a day, okay, so what would that look like in the next part, which is objective? He's going to be maybe reporting a decrease of intensity of daily symptoms and decreased frequency of these episodes. Maybe even better, you try to quantify it. He will be scoring less than a 10 on the PHQ-9. You try to, how am I going to quantify that we're moving toward that? Now, insurance plans love this because not only am I saying my goals are only looking at the diagnosis, which of course is not 100% true, but I have some ways that I can say down the line, how's he doing with those episodes? It's even better to say like, oh, currently he's having, if it's, let's say, insomnia, currently he's sleeping 2 hours a night. And then so my objective is that he will be sleeping 4 hours a night. And now I can go back in a month and say, well, let's see how many hours a night is he doing. The more, again, granular and behavioral you can get this. Now, when I teach this, I always get psychodynamic and psychoanalytic clients, therapists come up to me and say, well, that's not my goals with my clients.
Too bad. Make it work.
I say, it's not true, though. You are working on all this other stuff over here that we talked about, but you are trying to help them reduce symptoms. Don't tell me that as a therapist, you want to see your clients continue to be depressed and anxious and have trouble sleeping. So just figure out the behavioral symptoms or the symptoms of the diagnosis that you are trying to see reduced. And then you can use the same goals. I want to see a reduction in these symptoms that my client is having. And then the second goal could be a more positive one. It could be, and we want to see an increase in this behavior. What is that behavior? Again, it could be sleeping. Once you've checked their check boxes, your second goal can be a little bit more. First of all, the second goal, I often go after insomnia as a separate one because almost all our clients have insomnia or some kind of sleep problems. And it's such an easy goal to go for because it's so measurable, right?
Yeah.
And it's so clinical and it kind of lasts sometimes for a long time. So,
you can continue to work on it forever.
Use it while you're working on this other stuff over here.
I love that.
Or it could be something that if this client is like really depressed and really because of they have no support system, I would not be averse to my second goal being increase this client support system, basically so they don't have to rely on therapy. Like I can sell to the insurance plan, look, I don't want to increase their dependence. So then what? Maybe they're going to found something routinely. Their objective might be that they'll find some kind of a support group outside of therapy, whatever it is that they will be doing to create a support system outside of treatment, where they'll be able to list 3 things that they do that gets in the way of fostering relationships. They will be able to identify 3X that they do, or they will be able to list 3 coping skills that they will use when they're depressed, if you're going after the depression one. That's another phrase that I use a lot, which is the client will identify and be using 3 coping mechanisms to deal with their depression or anxiety. So again, that's something that we can check back with. Okay, have you identified 3 in our work together? And are you using them out there? And if not, what's getting in the way, kind of thing. So
that's so good. I love that they're like cookie cutter templates, but it allows for you to plug in the specifics. So that's what makes it customized for each client.
I printed it out. It has a section for interventions planned, and all you have to do is go down this list and check the ones. And you can customize this, but I've pretty much put a whole lot of shit on here. And if you probably do a couple of these, now don't check off everything on the goddamn template. You just need to tell them, I've seen that before too. Here's somebody who's lost their mother, let's say. What are your main things that you're going to do with that person? Maybe you're going to do some grief trauma resolution, help them to identify obstacles to building their support system. So I get a general idea that you're on the appropriate track, but hopefully you don't have to write a damn thing. You just check your little box over there.
I love it.
So
good. And do the interventions, do they have to be evidence-based interventions? Like it has to be based in CBT or EMDR, or I'm trying to remember the old United Behavioral Health, had they had those like criteria. Does it need to be based
I think
on
that there's a misnomer that the only kind of treatment that insurance plans will pay for is CBT. That is not the case. However, I would say don't get too over-reliant on non-CBT. Be able to check that box as one of the things you do. Again, when psychodynamic people come to me, they say, I don't do CBT. I said, oh, really? Like you've never helped a client identify how a behavior that they're doing is connected to their thoughts?
Yeah, right.
I think all of us in some ways use psychodynamic, and I think all of us in some ways use CBT. And I think you just give them a flavor of kind of some of the main things you do. But I wouldn't say I would ever check off one of these things because we're all a little eclectic, I think.
Yeah.
If it were me, I probably would stay away from just checking psychodynamic or psychoanalytic. Some of them are going to be more straightforward. Like I said, if I lost my mom, if you just clicked off grief therapy, I think that would be fine. Like,
yeah, totally.
I mean, it's reasonable. However, after 6 months, if you're still clicking that box, they may at that point say, is there something else going on, a deeper depression that you need to change your diagnosis, and maybe also start treating a deeper depression than just, I'll say just grief that minimizes grief. You might even want to put that in a treatment plan, rule out underlying depression that goes beyond the grief. But you don't need to spend a long time on this.
Well, and I want to point out too, one of the amazing things about Barry's, and I always joke about this, is it'll write a progress note for you and a treatment plan, and it's already trained on looking for evidence-based interventions. So it's funny, like sometimes it'll write a note for me and it'll say, clinician used systematic desensitization to help the client, blah, blah, blah. I'll read it back. I'll be like, I did. I'll be like, I did do that. I don't even realize sometimes that it, like you're saying, just to play on what you're saying, like with the CBT or whatever, like we're always doing interventions like that anyway. And then using Barry's with this template, it's going to pull from your assessment. It's going to pull from your diagnosis. It's going to pull from past progress notes. And it's already going to pick up on those interventions that you've been doing anyway. And it's even going to fill in the boxes for you. The AI is going to fill in the boxes on Barbara's treatment plan for you that you're already doing that you may not even realize you're doing, which is the amazing thing about being able to use AI with this stuff.
But Kim's making a good point, which is that you need to check over.
Yes, you do.
And make sure two things. Number one, yes, those are the things that I want to select out, because there could be a lot of possible goals. As we said, there's no this box and that box. And also, is it said exactly the way I want it to be said that I can back up? And so make sure you're reading anything.
Yeah, double check it before you sign anything.
Yep,
And,
yep.
you know, of course, go over it with the client and all that good stuff. But yeah, I love that. So,
Well, I should say, I don't go over it with the client.
okay, see, I'm glad you said that, because I always throw in that caveat. Maybe it's a misconception that we're supposed to review these with our clients and then have them sign off or whatever.
There isn't a supposed to out there in the world. Like, again, insurance plans don't say you have to, for the most part. I don't think I've ever seen it except in Medicare. Now, again, Medicaid is different in every state, so you might want to check on that. But Medicare would like you to go over it. Now, when they say go over it, they're not clear about exactly what that means. So you could review it in a verbal way about, well, these are some of the goals we're agreeing to. For me, that's what I would do. I don't know, for me, I've never felt comfortable pulling out a treatment plan and saying, well, here are the diagnoses I've given you, and here are my goals. And when you and I have this little box over here, that I really don't want to focus on this box over here, which is very clinical and diagnosis focused and symptom focused. And it's not that that's not real. I never tell you to lie in your documentation, but what do I want to focus on with the clients? If I do talk to them about my treatment plans, which I was not a Medicare provider, so I didn't have to. If I had been a Medicare provider, I probably would have gone over it in a more general way with them and just said, these are some of the goals we're agreeing to. Is that right? And you would like to feel less depressed. Oh,
right.
You would like the frequency and intensity and duration of your depressions to go down. Like, is that what? It's not that it's a mistake. It's just clinically, I think you have a little leeway as to what does go over it with the client.
I love that. Yeah.
For Medicare, they would like you to sign somewhere that you went over it with them. And so whether you make that separate in your chart or whether you have them sign the actual printed out treatment plan.
I love that you said that. Yeah, that's so good, because I think that's one of those ambiguous sort of things, myths, I guess, even for myself, that you kind of believe that you're supposed to be showing them the treatment plan, if you're insurance based anyway.
I've never heard anyone, that therapist, get in trouble for not doing that.
Awesome. So that leads to that last part, and you've kind of touched on a little bit, like what are some of the common mistakes you see with therapists that are writing treatment plans, with all the ones you've worked with over the years?
So let's summarize. Putting in 55 goals.
Okay.
Not doing it at all is a mistake. Probably the biggest one, though, is making it not medically necessary. You take the time, you do a great full treatment plan, but then I look over the goals. Oh, that's another one. Well, let's stay with that one. And the goals are, the big hot button is self-esteem. As soon as I see that, you're dead in the water. Like, you've just blown your whole treatment. Don't focus on self-esteem. Don't make it focus on relationship. If you are focusing on a relationship issue, make that your second goal. First goal writes itself. Reduce symptoms of diagnosis. That's how simple your first one can be. And then your objectives can be, like, what's that going to look like? She will be having less than 3 episodes of depression a month. She will be getting out of bed each morning. And you're all going to say, oh, well, my clients are not that severely depressed. That's easy to write a treatment plan for. What about my high-functioning depressed clients? Yes, I know. Good luck. No, but all of our depressed or anxious clients are impaired in some way. Are they having trouble speaking up at meetings? Are they having trouble falling asleep? Again, it's such a good one. Are they having trouble concentrating? Oh, that's the other thing that I sometimes do is I go back to the DSM, open to the page of major depression, even if your client's not major depressed. It has a list of 10 symptoms. Oh my God, it's a cornucopia of things you can use there. Loss of concentration, loss of pleasure, difficulty sleeping, oversleeping, the loss of appetite, overeating. There's all kinds of great stuff in there. You can go, oh, yeah, those things. If my client was not depressed, they would be doing these things differently. So use that.
Yeah.
Okay. So what were we saying? Mistakes. So not choosing medically necessary goals. too many goals. I guess not updating them could be one. Another one that is you have to be careful about is you haven't done them a treatment plan at all. And then the insurance plan calls and asks for your rights and says they want to see your treatment plans and your notes for the last 6 months before they pay claims or something. And now you're in a quandary because you didn't do it in the first place. You either have to fraudulently concoct a backdated treatment plan that wasn't there along, so that's fraud, or you have to send it in without a treatment plan, and that's 100% not going to be paid, right? So
Yeah.
this is one of the reasons to do a treatment plan is just so you don't have to deal with the stomach pain that even the thought of that gets me right now thinking
Me
about.
too. What a nightmare.
You just want to be like, I'd rather fall on my knife of not having a great treatment plan than having to decide whether to commit fraud. You don't want that. Even if you're update every 6 months, you just like write the same treatment plan and update say yes, and you change the date and update it. At least you know there was something up to date. And I want to say that there can be good things that come out of having treatment plans.
Right. To actually have a plan.
I mean, once in a while I kind of go, oh, the diagnosis that's on there, is that really what I think that they still have? And have I really looked at it? And, they came in for grief or whatever 6 months ago, and yet they're still pretty down in it. And have I really thought about maybe there's something deeper going on? And sometimes it kind of gets you to rethink about, and it's a nice opportunity to sit down with your clients and say, hey, let's do a treatment update if you don't do those regularly. Let's look at what you wanted when you first came in here and you said were your goals. And let's look at how far we've come in treatment and what's keeping us from getting farther if we're stuck in any way, or have we plateaued in treatment? Is there anything I need to be offering you that I'm not? Is there anything that you are feeling like you're not saying or whatever? So I think it's a nice opportunity to say, maybe let's take a look at treatment and see where we're at.
That's awesome. Really good suggestion. I love that. Yeah, great. You've just made treatment plans really painless.
Well, not painless, but
a lot easier.
But yeah. I hope so. And I hope once you do some, and again, if you take my 10-minute treatment plan training, you walk away with some actual examples. Here's a depression one. Here's an anxiety one here that you can like print out and just use them. And it's filled in my templates so you can use.
That's amazing. So all the trainings are on the insurancemaze.com, right?
Uh-huh.
Is that where they find all your trainings?
The store page, yes.
The store page. Awesome. Okay. And anything else you want to say as far as things you offer or that people could access of yours?
Well, just if you aren't proud of your notes, we addressed this last time, but documentation is a big one. I told you last time, I think, when I started out that I was just trying to help people with insurance, and then it worked over to now I help probably people more about documentation because that's where insurance plans are getting us. So keep focusing on that. And yes, there's lots of trainings on my online store, The Insurance Maze. Don't forget the theinsurancemaze.com /store. There's all kinds of trainings. There's all kinds of forms, packets. There's all kinds of good stuff, resources, and lots of articles.
Amazing. Are you still sending out your newsletter? You're not doing the newsletter anymore, are you?
No, yeah. I just sent one out last night.
Oh.
So if people want to get on my free newsletter, it's theinsurancemaze.com /contact, and you will automatically be added to the list.
She has the best newsletters, you guys. Sign up. I got to go figure out where they're going because I used to get them every time. So I don't know what happened to them. But anyway, thank you so much for being here. And thank you for giving your template to Barry's users. I think it's just amazing to have that resource. We've got your progress note in there now, and now your treatment plan. Gosh, with AI and your templates, documentation is going to be a breeze. Thank you.
Well, thanks for inviting me.